I welcome all of you to this 93rd lecture in the lecture series in Nonlinear Dynamics conducted by the Department of Nonlinear Dynamics, Bharathidasan University, with the support from RUSA 2.0. It's my great pleasure to introduce today's distinguished speaker, Professor Klaus Lehnertz. Professor Lehnertz received his doctorate from Helmholtz Institute für Strahlen and Kern Physics, University of Bonn, that is Helmholtz Institute for Radiation and Nuclear Physics of University of Bonn, in the year 1998. He got his habilitation and became a Prabat docent at Faculty of Mathematics and Natural Sciences at the University of Bonn in the year 2001. By 2008, he became the full professor at Bonn Medical Faculty. He is a member of German Physical Society, DPG, and is the co-initiator of the International Seizure Prediction Group. From 2001 onwards, he is the specialty chief editor for networks in the brain system in the Journal of Frontiers in Network Physiology. He has several notable publications in the area of his expertise, particularly in epilepsy and nonlinear dynamics. He has given several lectures and talks in many conferences across the world. During his career, he has already guided more than 30 PhD theses in physics and MD thesis in medicine. He has authored 220 publications in peer-reviewed journals, 70 book chapters, and 2 books, and he has an H index of 67. Very creditable. We are very fortunate that Professor Lehnertz could join us in this lecture series today. With this short introduction now, I invite Professor Klaus Lehnertz to deliver his lecture. Over to you, Professor Lehnertz.
Thank you very much, and thank you very much also for this kind introduction, very kind. Yeah, it's a pleasure to be with you this afternoon. For you, for me, it's in the morning. Yeah. This will be today some interdisciplinary talk. It's not just related to nonlinear dynamics and also not to complex networks approaches, but the idea is here to what can we use with, if we use these different mathematical physical techniques, can we also do something more in a disease like, for example, epilepsy? I will start with a very brief introduction into this disease. I think everybody heard about this, but many people are probably not aware of what this actually is and what the problems behind are. And I will then give you some kind of a brief overview of what has been achieved over the last 20, 30 years with approaches that come from nonlinear dynamics and more recently also from the theory of complex networks, in order to improve the understanding of epilepsy and hopefully also in the direction of developing novel treatment options, or in general a much better understanding of this disease. As you can see here, this is one of the probably most complex systems that we are currently dealing here, namely the brain, which is not just by its construction extremely complicated. It is of course a network, but it is something that is related to an issue that is still not really solved, namely the relationship between structure and functions. Something that can be in such a system that is represented there. You see, that's a nonlinear system. It is dissipative, it's adaptive, which is the most critical aspect here. So it will change over whatever time and spatial scales. Spatial scales are of course restricted to the size of your head, but any kind of modifications that you can see there, be it in the connectivity, be it in the arrangement of whatever ingredients you have, can lead to modifications, not just of the structure, but also on functions. And the functionality, this is of course something You see here on the top right some aspects that can be clearly described, and also there are ideas from the neuroscientific community, also from psychology, where we have at least a little bit of an understanding of what this actually is. But if it comes to something like personality or self-identity, for a physicist, you might ask, how can we measure something apart from some paper pencil tests also? The other issue is that it is an open system. That means we are always in the presence of some fluctuations. That might be some kind of fluctuations that comes from the outside. So any kind of disturbance or perturbance, so anything that comes from via the input channels that you have, can modify the system, again, on various different timescales. But also, and this is also something that is extremely complicated in such systems, that intrinsic fluctuations can also make some kind of changes. And this is something that makes the whole story extremely complicated, with the problem that whenever you have some kind of a coexistence between let's put it in quotes, some kind of normal functionality up to some kind of dysfunctions, and this is then something that you see some kind of a transition between ordered state and some disordered state. Of course, it's not clear what ordered and disordered here actually really means, but it is mostly like with many of diseases that the diseased state looks in its full expression more ordered than the normal state, which would be then some kind of a disorder. So it is not like the characterization of order in this sense, but the deviation from the disorder that would be the approach here in order to better understand how the system develops from some kind of a normal behavior into some diseased state. And one of disease state, this is the epilepsy. Epilepsy is the Greek term for seizure, and this is, of course, something that probably many people associate with this kind of disease. It is not a disease that is clearly defined, but it's some kind of a conglomerate of many aspects of some kind of dysfunctioning that can be traced back, of course, to the brain. Maybe more. This is not clear right now. But it has, of course, then many consequences, but because it affects basically the whole body. As you can see here, this is one of the oldest diseases known to mankind. It was first described 7050 before Christ. And this is quite fascinating to see that even though we know that long time about all these different effects that we have here, we know basically nothing about this disease. Anything that we know in humans comes from observations, and anything that goes in the direction of basic mechanisms basically comes from experiments done in animals or in slices of the tissues. So you take out some brain region and then try to understand what is going on there. You modify the behavior of some animals and then see under some free of some restrictions that you can then say, okay, that looks like, but still what is missing at the end is the translation to, is this really what we see in the human? And this is so far not clear. You also see that it's about 1% of the world population that is affected, just from the WHO, the last publications from 2019. It is roughly about 1%. Many countries, it is not even characterized as a disease because it could be some kind of relationship to some kind of religious behavior. And in that case, many people would not even say that this is a disease. So this is highly fluctuating. I have mentioned here some famous people that suffered from epilepsy, from which we know that they suffered because they outed themselves, or there were some kind of descriptions of their behaviors. And yeah, you see, this is nothing that is restricted to some specific kind of functionality of the brain, because what I've done here is of course really famous people, among them also physicists and poets and many other famous people that suffered from this disease. What most people know, as I said, this is the seizure, and the seizure itself is nothing else but a short-lasting dysfunction of this brain that can start locally and then spread over the brain, but it can also stay locally, and it might start globally. And then you need to ask on what is the distinction between this? What is typically done is that you assign some specific brain region, as it's indicated here, to be the origin of seizure activity. And here's some recording, a short sketch of the time far away from a seizure, and here you see the beginning of a seizure. This is measured with electrodes implanted into the human brain in brain regions where we assume that the seizure starts there, and you can see that there is some kind of low amplitude, high frequency activity depending on the brain region where you record this from, that then spreads over some time. This time scale that you see here is just a couple of seconds. The transition from the seizure into the seizure, out of the seizure, this is something that is not fully understood. What we observe here are some kind of state transitions from something that looks highly complex, or some people also say that looks irregular. This is the disordered state, into something that looks then more regular, and then again back to this state that you had been before. If you ask just from physical reasons, why does this happen? What is the underlying mechanism that either the whole brain or only some part of the brain is being organized into some kind of more ordered dynamics, and then all of a sudden it stops and goes back. Sometimes it doesn't stop and it doesn't go back, and then you have really problems to get the patient out of such a state. It's not clear what are the mechanisms here. Yeah? Some people say that must be because it looks synchronous. Some people say that it is some kind of a synchronization phenomenon that is underlying, and at the end it's probably some kind of a desynchronization. But I will show during my talk that this is completely misleading. So whenever you go I look at the seizure and then I go back or forward in time, and then I say that must be something like or something like, this is completely misleading. What is known, for example, some facts about these is that the frequency of the occurrence of these seizures, this is not what is critical in the disease. Yeah? For many people, of course, it is the seizure that is something that is obvious to the society or to the environment. But for the patients, it's mostly the time in between the seizures. So the normal life, which is somehow disturbed. If you look only at seizures, you will typically find on average over this 1% of population, roughly 3 seizures per month, but it could also be several hundred seizures per day. So this is the range of data that you need to take into account. If you ask, is there some kind of structure of the occurrence? If you look at the data, you will mostly find that the interseizure intervals look like prosonally distributed. This is taken here from a study. This is already 30 years old. Today, with more data, more access to data, we know that these tiny bumps that you see up here, typically on the time scales here, that could be related to sleep stages. And today we also know that not just the classical biological rhythms play a role in the seizure generation, but also any kind of long-range rhythms that because we are living on Earth, might affect the occurrence of seizures. So basically what you have is something that looks Poissonian with some kind of structure on top. Yeah? And the structure comes from something that can be explained due to some biological rhythms, but the rest is fully unexplained. The occurrence, if it's not related to something like what is shown here, the exception like a reflex epilepsy or something like in women, the catamenial epilepsies, if these are not related to something like an external trigger, it is apparently non-predictable. It is typically short-lasting, so roughly in the order of 1 to 2 minutes. And there's one exception. This is what I just said. This is the status epilepticus. This is something that lasts for more than 5 minutes. This is the standard definition from today. And if you enter in such a state and it is a convulsive state, you have roughly 30 minutes to get the patient out of the state, typically with a deep narcosis. If this doesn't work, the patient will die. Quite easy. There's also this non-convulsive status. If patients are in such a state, they have a survival time. This is much, much longer, really much, much longer. That could be days or even months, they behave strange in that time. And strange behavior in some subjects typically then looks like, oh, they are a little bit dizzy. So even the distinction between, is this now a seizure activity or not? Is this related to epilepsy or is this something else? It is not clear what this effectively is. During the seizure, what you observe there in terms of not just the EEG or the brain electrical activity, but what else is being altered, what you will find is a complete range of something like impaired mental functions. You have some strange effects like I feel something, I hear something, I smell something, something that you have never experienced before. It could also be the opposite way. I think everybody knows the déjà vu effect. I think nobody knows what a jamais vu is, namely that your brain tells you that you are in a state that has never been before. And it tells you, hey, this is new. This is something that is completely weird in order to understand, up to loss of consciousness. And then what is typically seen are mostly these involuntary movements, which then brings the association particularly in some societies that the patients are somehow related, or this behavior is somehow related to some devil or some godness or whatever. Yeah? What most clinicians don't see is this.
Excuse
Yeah,
me.
yeah.
Very often one finds when the patient holds some iron or something like that, the seizure stops. So is there a
Yeah.
mechanism of controlling seizures you are going to talk
I
about?
will come back to this point of
Okay.
controlling seizures. I will go into these details and also what nonlinear dynamics can do there with control techniques and so on and so on.
Okay.
Yeah, but just let me give you just a short introduction of what this effectively is, such that you will understand the problems behind it.
Sure. Thank you.
Yeah. Okay. So what the clinicians or most clinicians don't observe is the time during the seizure, because when the patient comes into a clinic, the seizure is already over. So what they observe is the time after the seizure, and what you typically have here is, in the best case, some kind of a neurological dysfunction. People could also be depressed, or they are fully reoriented and behave as if there was nothing. Yeah? So, and then as a clinician, you are faced with the problem that you need to tell, is this now a seizure or not? Or is this an indication of epilepsy or not? We have three main types. These are the so-called generalized seizures that appear apparently instantaneous in any brain region. What kind of mechanism could this be, that you say, I take the 10 to 9 neurons and the 10 to 13 glia cells to generate within a couple of milliseconds exactly the same kind of activity? This is not known how this can work. So even this description here might not be valid. Yeah? And then you have this focal seizures that start locally in some brain region and then can be with or without generalization. Control. That was just one question about, can we control this? This is just some figure here that shows the number of licensed epilepsy therapies that had been developed over the last 60 years or so. So it starts in the 1816 with some chemicals like bromide, and then 40, 50 years later with phenobarbital, and then many other drug diseases that had been, drugs that had been developed. And what we have today, this is this rapid increase here over roughly 10 years. This is basically drugs for each and every active neurotransmitter in the brain, either as an agonist or an antagonist. And if you now ask, does this work? No. This is the funny thing. Yeah. So we have access to anything that has been somehow related to the chemistry of the brain, and that will not work. You can ask, what does this mean if you change, if you take one of these drugs and you need to combine this with another drug? This is something that is being done. This is effectively some combinatorial problem, because you need to go for 40 faculty, roughly 40 faculty different combinations in order to judge, is this effective or not? And effectiveness is currently defined as, you're not treating the epilepsy. This is the reason why I put this here in brackets. You're not treating the epilepsy, but you try to reduce the occurrence of seizures. If you reduce something from several hundred per day to, let's say, 10 today, then the patient will be satisfied. If you have somebody who has 3 seizures per month and you reduce this to 2 seizures per month, then that might not be satisfactory. But this is the standard definition worldwide about effectiveness of control of seizures, not of epilepsy. What is also in between are new devices that try to control the brain via some kind of stimulation. That could be electrical stimulation, that could be magnetic stimulation. This is it is done, it is currently being done, but it also has some drawbacks because it requires some knowledge about where are the seizures generated, when are the seizures being generated. If you try to disrupt the seizure with an electrical stimulation, take into account you have roughly 1 minute time. You need to have fast-acting methods to allow control of seizures because the seizure will probably end anyway. The only thing is then probably if you are in a risk that you will go into some status epilepticus state, for example, that would be, of course, an option, but this is rare. Yeah. So anything what you have here in terms of control is not like I would like to disrupt the seizure because this is already the state that is probably not controllable anymore. It might be something that you can use these type of devices to control the brain such that it will not develop into a seizure. And this is like taking drugs. This is either a constant or some kind of a repetitive stimulation of the brain, or you do this really in some kind of very specific manner, but that requires much, much more knowledge about when and where are seizures being generated. And this is also an aspect I will come back to again. If you look at the success rates of these different approaches, and this is exactly what I was just talking before, reduction in seizure frequency. Yeah, this is something that you can see in roughly 70% of the subjects if you take anti-epileptic drugs. The side effects just comes from long-term treatment, and that goes from whatever is being changed if you alter the chemistry of your brain. The other part is, this is the option that is used for people that are not treatable with anti-epileptic drugs. This is epilepsy surgery. That means what you are doing is you need to identify the brain region where you assume that the seizure comes from. Then you need to simulate what will happen if you take this brain region out. And if you can identify that you have a higher success rate in controlling the seizure with a minimum of the deficit that comes from this intervention, any kind of neurological deficits from I can't move anymore, I can't speak anymore, I will lose my memory, whatever can happen if you modify the brain, then you will see the success rate on average is about 60%. And you see a huge range of, or a huge variability in success rates, which is, interestingly, time dependent. So the initial success is typically in the order of 80 to 90%, but then because it's you modify this brain network, it goes down to 15%. And at this point, you need to ask, is this what you do here in terms of surgery, is this incomplete? Is this insufficient? Or is this something where the brain, and sorry for this word, cares a shit about, yeah, if you modify this? Because it's some kind of a network that don't want to be controlled. This is another option that you need to take into account. Neuromodulation is something that I just mentioned before. You see there are many question marks. At the moment, the success rate is roughly 50%. So 50% of the seizures are being reduced by some random stimulation of the brain. You could also argue you have modified 50% of the normal activity such that the brain does not occur, the seizure does not occur anymore. So however you define this, you do some kind of a modulation of the brain, but what this effectively is, and if it now modifies the normal function or the dysfunction, this is largely unknown. And this is then the issue that you have here, that again, you have, of course, if you stimulate the brain, you have side effects. And on the long term, nobody knows what is going on, because this is something that is currently roughly 10 years old. And in many countries, you don't even have access to such stimulation devices. So it is not clear if this is really a good management technique. Rare is you bring the patients to modify themselves, yeah, in terms of some kind of self-management. The success rate is rather low, but this is low means many people or many patients just trust these techniques here. So you start typically with drugs, Surgery on the brain is, of course, something that nobody wants. Implanting some electronic device into your brain such that it will be controlled by something artificial. This is also something that is not quite nice for many people. Yeah, and then self-control means that you need to be aware of your own disease, and this is also, just from the psychological point of view, something that is hard to explain to subjects. Okay, so what can we do in order to improve our knowledge on the dynamics that we are measuring here? And as you can see, there are many electrophysiological recording techniques available, even in human subjects, and many of them are only allowed to be used in epilepsy patients. What you typically find is the surface EEG, so from the scalp recorded the electrical activity, potential difference from the scalp. You might measure the magnetic counterparts with either typical NEOP squid systems, or at the moment there are also optical pump systems that are currently being measured that you can also use them in an unshielded environment, and you don't need to go for helium anymore. What you typically find here, this is the frequency range that is being measured. This is DC up to some 100 Hertz that you can identify. People say this is the classical range of activities that is relevant, coming from some observations that a neuron, and now comes the critical part, the neuron just fires with a typical frequency of every 5 milliseconds. You have some dead times in between, so 200 Hertz is maximum that you can observe, but it's not clear if this is really true. There are some reports where people say, no, let's open our amplifier, open the frequency range, and you see activities up in the kilohertz range. What this is not known. The other issue that you have here is the small amplitudes that need to be measured. This is typically in the microvolt range. There are much higher activities that come from other parts of the body, particularly of the heart and of course of the muscles. And if you go for the magnetic fields, depending on what you measure, where you measure, this is the average, this is femtotesla range, but typically brain stems, attotesla, up to picotesla in the cortex, so something in between. In a non-shielded environment, take into account the size of the Earth magnetic field, and you are moving in this field, so you even induce something there. If you go into the brain, this is then something that is allowed in some subjects with epilepsy. That means you can implant electrodes that are being either then put onto the surface of the brain or implanted into deep brain regions, like, for example, in that electrode here that targets the hippocampus and the amygdala, deep brain regions that are responsible for the formation of memory and storage of information. This is then called the electrocorticogram or the stereo EEG, and you can also measure local field potentials with this. And this is, you see already here, the frequency range is broadened, and also the accessibility of the data is much better. But it comes to the problem that you also increase the locality. You don't have the more global view to the brain, but you are really restricted, and it's getting, of course, then very highly invasive. And if you want to go then to the level of single cells, these are techniques that have been developed over the last years, and some of them are now already accessible. And this is also something that we do here, namely that you take these DEPS electrodes, for example, here, and you have then some kind of fiber bundles that target from some micromanipulators outside of the brain, target single neurons in the brain or single cells in the brain. And there are many new recent developments like this one here that is brought into the cortex, or any other small scale tiny structures where you have already the electronics on board in order to measure something. Many question marks again here. Interestingly here also, if you go down again to the single cell level, you will lose the amplitude range, but what is effectively the signals that you are measuring here? What is relevant and what is not, largely unknown. So this is the data that you have. Anything else comes from other techniques like functional imaging techniques, and also the functional imaging techniques. But these techniques here are the only ones that record continuously the spontaneous activity, and you don't need to go for any kind of relative measurements. What you need, for example, to do in terms of fMRI. You can't measure the ongoing activity, but whenever you want to say something about the signal, you need to have some kind of a relative measurement, requires some kind of an experimental design in terms of what is a good experiment to probe for something. That can be questioned. The other issue that you are faced with is that the brain dynamics itself is depending on the point of view, either noise or some signal. Yeah. So on longer time scales, what you observe, like it looks like a 1/f like noise. It is mostly scale free, and what you observe in between, and this is the reason why it's then called, are some kind of nested oscillations. And this is, if you are looking for just, if you try to interpret the EEG, not with some kind of mathematical tools, but you just look at the EEG, what you will find then is here some kind of rhythmic activities that can then be classified in amplitude and a typical frequency range. And this is what neuroscience is mostly looking at. So nested oscillations that occur on some kind of an irregular scale. And this is then what you typically find as a description of the EEG, namely the frequency bands, delta, theta, alpha, beta, gamma, and so on and so on. And yeah, this is one way of description. But the other way, namely that you consider this as some kind of a complex dynamics, this is only recent. And it has, of course, the problem that it looks like noise. And then, of course, the question comes, is this really noise or not? Is there some kind of message that is being emitted from the brain in order to understand what is going on there? This is what you see in time. You also have the problem that the translation of scales, if you go from the recording of signal units to the gross activity of the brain, this is also something that is not understood how this actually works. So scale bridging from activities of the single unit activity, which is typically assumed to be some kind of spiking activity that then goes into something like oscillations. It is not a simple linear superposition. This is for sure. It could be some kind of a nonlinear transformation. It could be some kind of a modification of activities that are somehow modified by the physical properties of the tissue in between. But if you ask what are the physical properties and how can we measure this, then you will find nothing in the literature, and you will not even be able. There is not even an idea of how to measure, for example, the conductivity or the resistivity or the permeability of the living human tissue without destroying the tissue. So you can do this, of course, you take it out during surgery and do some kind of measurements, or you go to the butcher and take something from the cow or pig and then say that is related to humans. Somehow it is not clear how this really looks like in humans. Yeah? So scale bridging, time scale bridging, spatial scale bridging, this is something that is largely unknown how this works in the human brain. That was one of the reasons why people started to go into nonlinear dynamics and ask, what can we learn about seizures? And that was, of course, a time where people, so almost 30 years ago, people asked, okay, we have now all these nice techniques that allow us with some kind of embedding to estimate your upper of exponents or dimensions or whatever you have in order to characterize a complicated dynamics, and also the transition from something that looks like noise into something that looks like a regular state. And if you study seizures, you have the impression that looks like low-dimensional chaos. Now, it looks like. Showing that it is really low-dimensional chaos, this is still under debate. And we had a conference together with Peter Grasberger back in the 90s here in Bonn, where we really questions the issue of, is there really chaos in brain? And at that time, and still think that many people are still with the same opinion, that it's indeed hard, if not impossible, to prove that you really have some kind of low-dimensional deterministic chaos in the brain. Anyway, what has been done is with these techniques, they were used in order to have another type of characterization apart from looking at frequency bands and then saying alpha band has its power off. And this is some kind of a relative description. But here we saw that using these techniques, you might learn more. about the brain. If you concentrate on nonlinearities, if you concentrate on stability of the EEG or of the brain expressed by its dynamics of the EEG, if you look for dimensionality changes of the dynamics in the course of time. And there were many aspects that then led to the effect that you learn more about the seizure dynamics, you learn more about the effectiveness and the mechanism of action of anticonvulsive drugs. If you look, for example, you have some linear technique. This is just a part of the brain, and everything that is reddish here would indicate to the surgeon, take this out. And if you concentrate on the nonlinearity in the data, it is only this small region here. So that goes from several square centimeter to just a few square millimeter that would be then an option for the resection. And that was, of course, one of these big advantages, and with something that is also now included today, where people say with simple techniques, we can try not to go for really large surgery, which is in many cases still the case, but where you can say, okay, let's go more on focus in order to spare the tissue. Anything else that was in the so-called pre-surgical evaluation? So you have a patient, you want to do surgery, you don't know, can I do this? And whatever you learn about the brain, how can we do this? There was an improvement by using just these many nonlinear techniques in order to identify what is going on there. And we also saw that there are first ideas about there is something like predictability of seizures. Namely, here's one example here on a paper that we published in the late 90s in PRL, where you see that there's some kind of a dimensionality reduction. So the system gets more ordered already prior to the seizure, and already prior to the seizure was here in the order of a couple of minutes. Yeah, and that was one of these trigger points where people said, okay, let's go into other ways, not just doing surgery, not just doing application of drugs, but what else can be done? If we would be able to predict and we would be able to control, why not? Yeah, but what is a good predictor and what is a good control mechanism for seizures? Just to show that it's not magic what is done here, but concentrating on nonlinear measures requires that you do also some kind of a surrogate correction in order really to test for nonlinearities, and then you can go up in terms of some task. This is here the identification of the epileptic focus just from data where you don't have seizures. Yeah, so the clinician would say, why do you analyze this EEG? This is boring, there's nothing. Yeah, but even in the so-called background activity, you have this information, and you see that the correct classification can be vastly improved by concentrating on the nonlinear aspects, not just the classical EEG band power or some other parameters that are standard, which is also built in EEG machines. The late 90s then also triggered something that come from the field of synchronization theory. People studied also interdependencies in the brain, so any other ways of what is actually an interaction and how can we characterize interactions. And that was then what was also something kind of surprise, that if you look at the synchronization or measurements of synchronization along long time scales, and how does the synchronization level changes in the brain, you need to take into account you need synchronization in order for your brain to function. You have different types of synchronization, not just full synchronization, not a phase synchronization, not just generalized synchronization, but many other synchronization forms, including the formation of chimeras, can be observed in brain dynamics. And the idea was here, what is going on in terms of synchronization? If there is a seizure, and the classical option was always, there is some kind of a buildup of a critical mass, coming from nuclear physics, of course. And this is then, in order to have this synchronized activities, this synchronous activity, there must be some kind of a synchronization mechanism. What was observed was that any kind of seizure precursor that we saw is associated with a decrease of seizure, of synchronization. So it looks like as if the brain region that leads or that triggers the generation of seizures is being decoupled from the rest of the brain, which also somehow makes sense, but that requires a complete new way of thinking also for the clinicians to say, I don't If I see synchrony, I don't relate this to synchronization, but I need probably to relate this to desynchronization. No? And then comes the other way around, namely that if you ask, why do seizures stop? No? Typically, what you would assume as physicists, this is energy depletion. Yeah, you can measure the energy depletion during I put this in quotes because there is no energy depletion during seizures. Yeah? Any kind of technique that has been used, like SPECT or PECT, any nuclear medical imaging technique, has shown that it's almost constant. There is no change. What we did was we looked at the gross structure of the activity. So we used the eigenvalue spectrum of the correlation matrix and asked, is this what do we actually observe there if the seizure develops? And what you see is in the largest eigenvalues, so any technique that is based on principal component analysis and so on, they show you see effectively a desynchronization in the gross activity, but there is a re-increase in the synchronization prior to the end of the seizure. Prior to the end, you see a re-increase of synchronization. And that was data that we have done here with more than 100 seizures of more than 100 subjects. This is an indicator for seizures to stop. And fortunately, we had some data where we had recordings, long-term recordings from some subjects with the status epilepticus, so long-lasting seizures where people try or the clinicians try to stop this, and this re-increase that you see prior to the end of the seizure, this is exactly what you also see there. So completely new ways of thinking about how a seizure is being generated and how does it stop. The spreading, this is, if you look at the bulk activity here, this is hard to distinguish. How can we really identify what is going on? Is there what kind of spreading can you observe there? This is some work that is currently underway together with Chitaranya Hens to see if we can identify more pathways in the brain, not the classical pathways that come from anatomy, but some kind of dynamical pathways that would indicate on what brain regions are being infected during a seizure. But this is, as I said, that requires a little bit of more work, because with the current techniques that are available, it is not easy to identify something. The focal seizure and the spreading. This is exactly what is shown here with some kind of an intracranial EEG recording. You see, what the clinicians are typically looking at is the beginning of the seizure, which is here. And then you see the spreading. But the question is, where are the seizure precursors? Is this what you see here, this rhythmic activity, is this something that can be related to a precursor? And if you study this, then you see it has nothing to do with this. This is it looks like as if you have some kind of an ongoing activity, and the seizure is something that is put on top, something that emerges from that. But identifying the seizure precursors, this is not clear what this is actually done. That seizure is synchrony. This is also some kind of a traditional view, because whatever you find in textbooks is that the seizure is some kind of excess synchronized electrical activity in the brain, and depending on what kind of measurement techniques you use, for example, your nearest neighbor phase synchronization or whatever fancy techniques you use, you will see that there is something like this. But if you do more and you compare different recording techniques, so you concentrate on specific aspects of the different methods of synchronization, then you see that it's actually not an increase and not a decrease, but it depends on how you look at this. So even that is critical, because the decomposition of some signal like the EEG in order to say something about amplitude effects, in order to say something about phase effects, and even if you go for state space representations of this, it will give you completely different findings. And this is something, again, hard, where most people say we are not at the point where we can say we have understood what a seizure actually is. And this is one of the examples what I just showed before. If you look at this data here, you see this typical re-increase at the end of the seizure. And funny thing is that it depends also on which kind of seizures this is. So the local seizures, the local ones, they probably start earlier during the seizure time, where the transition to the attempt to stop the seizure already starts earlier. And for seizures that involve much larger brain regions, they do this on completely different time scales. What this is, as I said, this is not clear right now. You see, this work is also almost 20 years old. We are still working on that with other techniques to see what else can we learn from these synchronization mechanisms. But what we have now is the stopping of a seizure or the end of a seizure looks like as if it's a self-induced mechanism. And it's probably related to some synchronization phenomenon. But this is completely counterintuitive to the clinicians, to the neurophysiologists, and convincing these scientific groups is sometimes a little bit hard. Okay, I mentioned the seizure prediction. This is something that also in the introduction was already mentioned. The foundation of an international group that came effectively out of the idea that people have seen that with the development of nonlinear time series analysis techniques, there is something going on, and that required some kind of an interdisciplinary effort. And this is something that we set up here with a colleague from the US in almost 20 years ago, and we met regularly, and you see the number of people that are attending these conferences is more or less constant. It is growing in some sense, and people come up with new ideas on what else can we do, and this is also reflected here in the change in the name, that we are now going into completely different directions, also in control and better understanding of seizures, not just the prediction, because it is not only the prediction that we need, but also the other ways in order to improve on the on control of epilepsy and not just the seizures. Rough overview of what has been done during that time. So back in the 2000s, people studied mostly the red line here would be the onset of the seizure. This is also something that you need to take into account if you ask a clinician, can you define the onset of a seizure? Well, of course I can do, yeah, and then you get some data. Then you take another clinician from the same community, and you will get completely different answers. And then you go to another school and you ask them, can you define the onset of a seizure here? And what you end up with is plus minus a couple of minutes. A couple of minutes, yeah, which is hard. Because whenever you have some kind of an algorithm that tries to predict something, you need to take into account that you rely on the expertise of somebody who can read the EEG by looking at something. And they have, of course, in mind that a transition into a seizure is characterized as blah, 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 and then they have their complete list. And if they are uncertain, then comes the uncertainty. And the next school says something else. So this is effectively this line, what we have here, that anything that has been studied up to that point is highly not trustable. Yeah? Because it could be that you either see spreading phenomena or you have the uncertainties of the true onset of the seizure. And you need to take into account you have many onsets. Yeah? You can see if you just look at the patient, you have the so-called clinical onset. You can go for the EEG, and you have the electrical onset. It depends on what kind of measurement technique you have to say this is the onset of a seizure or not. So it is hard to understand what is actually what. So more trustable is something that goes into minutes before. And that was the first observation coming down here with the nonlinear time series analysis techniques that have shown that on average over these techniques and the data that was available, you have something in the order of a couple of minutes prior to the seizure. And if you go for synchronization phenomena, that was just in the beginning of the 2000s mostly, you can go up to changes in the order of a couple of minutes up to hours before. Yeah? And here are also some data that has been published during that time where people also say it is something like a waxing and waning of some activities, and this waxing and waning, of course, is then related to circadian rhythms or other biological rhythms, and on top you have some kind of other phenomena that look like some kind of resonance phenomena, and the seizure itself could also be some kind of a resonance phenomenon. Just a short overview of how this has been developed. The first publication of seizure prediction in the 70s, interestingly, by a company that built jet engines. It was McDonald something, not the McDonald's, but some engine company that built the engines for jet fighters. In the 90s, the first application of nonlinear dynamics theories to seizure prediction, and then the field boomed up to where we are at the moment, where we have already large databases to study epilepsy. We have now the transition that go into people using more and more machine learning techniques to separate some predefined pre-seizure state from whatever has been characterized as non-pre-seizure. This is not in the terms of prediction as it would be used also in that field, but it only allows some kind of a distinction. Machine learning is effectively nothing else but defining in some modern way some kind of mathematical discrimination function, and this is exactly what is being done there. It's a nice pragmatic approach, but it has the issue that it does not give you any kind of knowledge about what is actually going on there. Yeah? So the nonlinear dynamics was already complicated enough to tell a clinician, what does it mean if I see a change in the Lyapunov exponent? It's getting more positive, more negative, or whatever. You see a change in entropy, or you see a change in the dimension. How can you interpret this such that a clinician or a neurophysiologist would trust you? Now you come up with something like, I have a black box, I put some data in, something comes out, and that tells me you are in a seizure state. Could be, yeah, but this is something that needs to be taken into account, that this does not really help in understanding what is either the disease and what can we learn from this. The idea was, once you have a method that allows you to predict seizures, and you see these are old ideas here from Christian Elger and myself in the early 2000s, where we said, okay, let's have some system that allows us to estimate from the recording some kind of precursor activity. You can control something quite easily, either some warning system to the subject, up to some fast-acting drug that is being pumped into the brain, up to control of electrical stimulation, whatever is done here, even local cooling or some kind of self-control, whatever you want to do there. So this field is open. All of these techniques here had been tested, and it is shown that it works somehow. The only thing that was not shown that it worked up to that point was that you really can predict something on a long time scale. And that was the work here by Mark Cook and colleagues in Australia a couple of years ago. So they published their findings almost 10 years ago. It was a pure study on, is it possible or not? That was a feasibility study, and they implanted 15 patients with a very simple device, effectively. Today we know what kind of analysis techniques they use there. It was nothing else but some kind of a line length descriptor, so a very simple estimator of some fractal dimension. And they had some implantable system here, and that warned the patient to see in some kind of a green, red, yellow scale, you are in a safe position, or you are in a critical position, or you are close to a seizure state, and nothing else. Yeah, it was just a warning. And that study showed that it's indeed feasible. Prediction is doable, but not in all patients. And if you have a patient, then not even in all seizures of this patient. That was what was funny to see. Yes, it works. They have recordings up to 3 years, and at the moment there are still some patients that still have this this system implanted. So something like 10 years of data is available. If they make it available, if these people make it available, which is still under debate with them. But the question is, if it's feasible, where do these buts come out from? So, and why is this the case that it does not work in all seizures? Is this the location of the electrodes? Is this the algorithm that is being used? Is there something else? So that was not known during the time. And you see that the coverage that they had here was based on the assumption, we assume it is this type of this seizure, so it must come from there. And then they implanted the electrodes only to capture the seizure activity. Yeah? But precursors, a precursor does not necessarily mean that it comes from the same brain region, although it somehow makes sense to call this like this. But that was then a finding that came much later, that namely, if you study seizure precursors, and this is now from a large group of people that have shown this, that the seizure precursor is not in the brain region, can be identified not in the brain region
where the seizures start, but they are being generated in completely different brain regions, even in the opposite brain hemisphere. And that, this is this message here, mostly far off the epileptic focus, and far off means it is even the opposite brain hemisphere. But that depends on the epilepsy type, and it depends on what kind of measurements you are looking at. It is best identifiable if you study interactions. So any kind of synchronization or desynchronization mechanism. What was observed before that it's a desynchronization was exactly this finding here, where people looked at only interactions within the focus, but not more widespread interactions where you have all types of interaction between the focus with other brain regions, and even the interactions within the non-affected brain regions. You have some kind of a balance between recordings, between synchronization and synchronization. I just saw that there was a request. Can we do this afterwards? It's okay with you? Because it was something related to oscillations. I have no idea how I can respond to this now.
Yeah, please.
Where's I could not see this. Oh, it popped up, but I have no idea where it is right now. Is this in the chat function? Here it is. Will there always be a large amplitude oscillation at the onset of the seizure? No. Quite easy. It depends on the brain region where you look at. It can either start with a small amplitude and a high frequency, or a small amplitude and a low frequency, or a high amplitude with a low frequency and a high amplitude and a fast activity. It depends on the brain region. So your question makes sense, absolutely, but it depends on in which brain regions the seizure is observed.
No, but when you say seizure is an extreme event, so can you identify with some large amplitude oscillation?
Okay, coming to the definition of an extreme event. I mean, I had these discussions many years with Shyam Aldana from Kolkata. Amplitude is not the only indicator for an extreme event. This is something that is being used to say I have something that is in the fat tail. Yeah, but it could be the rareness. It could also be the smallness of something. It is a deviation from normal. But here we are faced with the problem that we need to define normality. Okay. And this is the point. If you take one extreme or you take the other extreme, the brain is always in between. Yeah, and this is also one of these problems. If you have a deviation from the maximum, then you will find something, but it could also be the deviation of the minimum. Yeah, okay. I'm not aware of any techniques that takes into account both.
Okay.
I mean, even in mathematics and in extreme value statistics, people only consider the maximum.
Yes.
Yeah.
Yeah, one can think of.
Okay. Let's continue with this one here. So the issue was that if you only concentrate on a specific brain region and say that it is going from here, it does not make sense, because this is also some kind of a philosophical problem to argue. If I see something, I observe some kind of an activity in some extended system, and I place some sensor there, and then I see something there. Can I really judge that it's being generated there? Only because I observe it there. And if I then study something like, is there something that is indicative of this occurrence there, and it comes from somewhere else? Then I'm lost with this concept of something that the clinicians and also particularly the neurosurgeons need to say, if I go into this gray structure and I need to do some surgery and you don't see anything, there is no modification, there's no tumor, there's nothing. It's only the changed functionality. Yeah, you need to know, you need to have some kind of a landmark, and this concept that they have developed here, this epileptic focus, of course, makes sense. Yeah, but in terms of understanding what is this and why is this being generated and why does it defy control and how does it relate to the normal functioning, that was some change that popped up in the beginning of the 2000s, or already almost 20 years ago, where we have now a transition from the so-called epileptic focus concept to the epileptic network. And in an epileptic network, you have the issue that you can say this is some kind of connected brain regions, not just in the sense connected in the sense of anatomically connected, but it could also be functionally connected. And this is also something that you see in the current literature, where many people say, I just need to measure with diffusion tensor imaging, for example, I just need to measure the connectivity and then I'm done. No, you're not done, yeah? Because anatomically is one aspect, but we don't know the exact relationship between structure and function. And if we take this as a concept here to say any kind of the brain regions that are within these epileptic network can be responsible for this generation of seizures, for the control of seizures, for the spreading of seizures, for anything that you also see in between seizures. Yeah? That requires much, much harder definitions. And this is something where people are currently working on with concepts from graph theory to understand this epileptic network. Just a few slides on that, such that you know what we are currently doing. So not knowing what is what. Yeah? You have again the same problem of scale bridging. Where do you want to go? To this single cell level, I used neurons here, but you can also use glia cells, or you need to go for glia cells, of course. And these are the vertices, but what is an edge? Yeah? You can say on the anatomical scale, this is a synapse. Then you go to the large scale. I put medium/large here, but what you typically have is, as a vertex, you assume that the sensor that you place somehow into this brain, that could be some kind of an electrode, that could be a voxel, whatever you use here, this is associated with dynamics of the networks of the neural networks, or the cell networks that you are measuring. This is then assumed to be a vertex. So again, some kind of a gross model that you take for this, and any kind of edges in between is then some kind of an interaction. And now it's the question to you how to measure these interactions. Yeah? Typically what you do in physics is probing, yeah? Actio est reactio. But in the brain, probing, in whatever sense you would like to do this is not easy to do. Yeah? So what people are typically doing here is then use time series analysis technique to characterize these interactions and properties of these interactions. Yeah. So if you have this, then you end up with something that is currently called the evolving brain network. So the brain network itself evolves over time, means that the edges, properties of edges can change over time. Even the vertices can change over time if you allow this. Some people would also say this is a multiplex network or a multi-layer network. You can work with this if you want. But the important aspect here is that it's indeed time evolving. And then, and this is also something that you would need to take into account if you look at network characteristics, not just the global ones, but also if you go down to the single constituent level, like you use, for example, centralities or whatever. These are static measures. There is no time dependence, but this is something that would need to be developed over the next years to see how characteristics of such an evolving brain network, how they depend on time. Yeah. And if you have this, then this is then particularly in the field of epilepsy, in hot topics, where are the seizure precursors in some networks? So where do they are? How do they emerge? When do they emerge? And if you know this, then you can also say, if I can identify something that is more or less something that is unique, then you can of course say, okay, that would be a target for developing novel control techniques based on network control. This is what people are currently working on. Just to give you some impact of also something that has been shown so far, just from the perspective of a network. So the epileptic brain networks themselves in structure and function, they differ from the non-epileptic one. This is already shown, large-scale studies where people have shown that they really differ on different scales. Yeah? So the epileptic brain is different. Yeah? But what makes this different? This is not clear right now. We know that it can be modified. Yeah? Any kind of cognition, for example, modifies the brain networks. Interestingly, if you look at other properties of seizure networks, for example, yeah, then they appear to be assortative. And this means they are less vulnerable to attacks, and that might also be some kind of a mechanism for seizures to defy themselves from control. Yes, just from looking at aspects of the network dynamics, you get some more hints about making some better understanding of what actually a seizure is. We mentioned already the increase here prior to the seizure, and interestingly, if you look for importance in a network and you use, for example, centrality to study what is effectively the most important node that you have in the brain, then it's not the epileptic focus. So it's completely contradicting to what the clinicians think. Yeah? What is important has nothing to do with epilepsy. And this is, again, something that is currently being worked on, where people try to understand, if I have a central node or a central link, can I trace this back to aspects of the pathology? What is then much more important is, of course, then the long-term dynamics. That requires that you can understand how these networks develop not over minutes, or what most people do just a few seconds, but over days and weeks and years. Yeah. Just one short aspect that has been identified. If you study, for example, network-based mechanisms of seizure generation, I don't want to go into much details here, but what is typically done, if you say that must be the seizure focus where you observe something, no, it is not. Yeah, you see interactions, and these interactions in the networks, they go along with some kind of a network reconfiguration in the sense that it is some kind of structure that you also observe during the seizure, yeah, but on a time scale much longer before, and it is not a seizure. This is the funny thing here, and what has been assumed before as it looks like a decoupling. Yeah, if you only concentrate on pairs of brain regions, then it looks like a decoupling, but what is effective here? It is mostly some kind of a formation of bottlenecks that hinder somehow the normal information flow in the brain, which then probably on time scales here, typically on hours, it builds up something that then at a very close state is then related to the structure where the seizure is then being observed. And depending on of course, also to be expected, if you use different centrality concepts, you will also find then different types of network reconfiguration, and also different types of either path-based or edge-weight structures that modify the brain regions. So if you just summarize this here with the control of seizures now, yeah. So we had these early observations where people only concentrated on, I look at what is going on in the epileptic focus, driven by this old concept. Yeah, it turned out it will not work. Yeah, we have tons of different mechanisms, but they don't work. We have the proof of principle study that an implantable system is doable, it is feasible, but it does not work in all seizures. So again, what is wrong here? Why doesn't it work? What else is being done? If you look at control techniques, you have many of these aspects, they mostly do something in the brain, and if you ask how, typical physicist question, what is the mechanism behind this? People don't know. Yeah? It is, I use some kind of an electrical stimulator, or I use some activity, I take some nerve and try to activate this. If you ask, mechanism of action not fully understood. If you ask, why do you do this stimulation with that frequency, with this kind of amplitude? Was always like this. Yeah? So somebody said something and then they do it. And this is now an FDA-approved method in order to control some disease. If you ask a nasty question, you will not get an answer. This is the fun thing. Most of these systems are not coupled yet to some seizure prediction system, so we don't really not know at the moment if some control technique that you apply during the pre-seizure state, that this will effectively disrupt the seizure. This is not clear right now. The other aspect is the definition of what is efficient and not. And what you find in every country on the world is such a device, if you want to control seizures, you compare this with drug treatment. Drug treatment is done on a time scale of decades, in the worst case, or lifelong. And this is something that acts locally in time and locally in space. So if you then go to the authorities and ask, is this comparison, if you compare the efficacy of a stimulator and the efficacy of a drug, is this really a fair comparison? They will raise their shoulders, no, we don't have betters. Yeah? So everything what you have here is not necessarily something that can be used to explain it makes somehow sense. The other aspect is that most of these techniques only target the old concept, namely the epileptic focus. Yeah. So the question is how to improve on that, and if you see you have already these limited effects here, and if you take just on average over all these different techniques, you end up with 50-50. Yeah. But that 50-50 could also be just related to the definition of what is really a good efficacy. So what you need to answer then is, it is some kind of a state transition, second order, first order, not clear what this effectively is. So people used the old concepts that had been developed in order to study state transitions. For example, what you also find in other systems where people study critical slowing down and many other aspects. They show that because in some systems, particularly in low-dimensional systems, they say, oh, this has to be something like a loss of resilience. That makes somehow sense. Yeah. So again, I have some method, I do something, and if it somehow makes sense, also in some theoretical point of view, then they trust this. Yeah. But is this really some kind of a tipping mechanism that has been shown there? So there are papers, and you can read these in very fancy journals like Nature, where people claimed that the state transition to an epileptic seizure is nothing else but critical slowing down. If you study this, is there really an indication for critical slowing down? You will find nothing. In the best case, you can find a critical speeding up, but not slowing down. If you ask, are there other tipping mechanisms in terms of, is there something like noise-induced tipping or rate-induced tipping or whatever mechanisms you can consider, you will easily find that these mechanisms have been designed for very low-dimensional systems. And very low means around 1 to 2. And I think nobody of you agrees or would agree with me that your brain is only 1 or 2 dimensional. So the concepts that we currently have, in order to understand also from a theoretical point of view, what is this kind of transition that we observe there? Not with the current techniques. So we would need to have something else. And if you say you have critical slowing down and you associate this with a loss of resilience, so and then you say, okay, I have a resilient brain if it's not pathologic, and any kind of change towards a disease must be some kind of a loss of resilience. Yeah, why don't you measure resilience in the brain? But then you also need to identify some new ways. Critical slowing down was the only one, but this is based on the on many assumptions that are actually not there, and other ways to measure resilience are not there, particularly not data-driven methods. We have developed one. I will just briefly go into that detail, what is being done there, but that's it. Yeah. So, but still, if you have this, and you see that if it's not on the resilience level, you need to also ask if the human brain wants to be controlled. Yeah, you can also revert argumentation and say epileptic seizure, the seizure itself is nothing else but a reset phenomenon for something that is going on in between seizures where people don't look at, and also the clinicians don't look at. Yeah, and the evidence that this might indeed be the case is something that we developed here with a colleague from Tehran, with Reza Tabar. Some measure for resilience. We call this not the classical resilience, but we call this here some method for resistance. We call this some kind of a dynamical resistance, which is based on the controllability of a network. What we can't control is the eigendynamics. This is something that is hard to assess. But the coupling function and also the adjacency that we have in here, this is something that we can easily assess with time series analysis techniques. And then it's just an issue of, if we look at similar structures that we see in state space, so basically the coupling structures that we observe, how does this develop over time? This is then what we use as some clustering in a high dimensional state. And what very easily we have of course different states that the brain can take, but there is something like a nasty state that could be the seizure state. Of course, we did this retrospectively to see is there something, and we see that there are of course then changes in the distance between the different clusters that make up a method for estimating resilience. And if you look at this, what you see then is that in most of these cases, more than 70% is most, you see an increase in the resilience or the resistance of the brain. And in that point, you need to ask, is this really a mechanism that is induced by the brain in order to say, don't stop me now, I need this? Yeah. So this is, of course, some kind of a completely different way of thinking about epilepsy. But you can also see that any kind of changes that you observe, they are controlled by circadian rhythms. And if you only take this indication here, this resilience estimators, they also have some kind of predictability of the seizures, because this is something, this large increase that you see here, this is something that you can't observe at any other times. Coming back to the impact of biological rhythms, this is also something that most people think that they know what we talk about here. Yeah? Take into account any kind, the rhythms that we are talking here about capture something like 11 orders of magnitude. Yeah? So from the activities that come from the oscillations of single molecules. There are some studies that have shown you take two molecules to bring them together, because they are on Earth, they will start with they start to oscillate with a rhythm that is related to the moon cycle, to the Earth, to the sun cycle. Yeah. So, and then any time scales that you can think of up to the point where you are dying, this is the time scales where you have some kind of rhythms that, of course, somehow act onto the brain. And that there is an impact on the brain oscillations. So the delta activity and the alpha activity, this is known for more than 50 years. Yeah. But people never looked at, and I mean, what they observed is amplitude changes, but they never looked at what else is going on. How does this really affect brain dynamics? How does it affect interactions? And more recently, how does this affect the brain network? Circadian rhythm is one aspect. This is largely known because this is easy to observe. Infradyne, so anything that is larger than 1 day, requires that you have access to really long recordings. And ultradyne rhythms, if you look at the literature there, this is sparse, because it has, again, the impact of what is this? Most people then look at changes that you observe during sleep, but what is going on during the day? Everybody thinks you are awake, but if you see the same rhythms over the day that you also see that are related to sleep, then you need to ask what is actually sleep and what is awake. Yeah? And just for a very simple example here, we used 2 data sets where we had enough recordings, namely 7 days and 40 continuous recordings, 7 days EEG, scalp EEG, and 14 days of a subject with invasive EEG with recorded in different brain regions, and here we have the scalp EEG. What we looked at was how do, for example, statistical moments change? Yeah? Take into account anything what you do in terms of analysis of EEG data is always based on the assumption that your data is Gaussian distributed. Whenever you do a measurement, whenever you do an experiment, yeah, you have the background activity. Whenever you concentrate on some kind of an oscillatory motion, you think the rest is noise. So I repeat my experiment, I do it again and again, and then the noise will cancel out. Yeah? But this only holds if it's Gaussian distributed. Nobody has studied so far how the skewness and the kurtosis of some statistical moment, if this is affected by the circadian rhythm. If you look for interactions, yeah, everything that runs under the umbrella of functional connectivity, something that is being done in the neuroscientific research community with MRI systems. So any fMRI system is, if you look at the data that is being sampled there, yeah, it is only a few snippets of recordings that you have over the long-term recording. They have, in the best case, something like hours, but not the full cycle. You need to ask, when are the measurements being done? Is it in the morning, in the afternoon? This is mostly accessible to a machine. Yeah? And if you have some machines that run in a clinical environment, you need typically go during night times or over the weekend, and you know what is going on there. So any kind of changes related to pairwise measurements of the strength of interactions, there could be some kind of a stupid Pearson correlation coefficient or more fancy things like phase covariance. And if you have this, because these are the basis here for constructing networks, you can also ask how do other properties of networks, are these affected over from circadian rhythms? So what is shown here is power spectral estimates of the skewness, of the variance of the skewness and the kurtosis at different recording sites. And what you see is that skewness and kurtosis, this is the red line that would indicate Gaussianity. So everything that is smaller than this red circle would be an indication for Gaussian data. You see that in most of the time, particularly during night times and in the afternoon, so depending on where you sample your data, you have strong deviations from Gaussianity. The same can be observed for the skewness. If you go for intracranial data, this is the part B here, you see that most of the time you have deviations from the Gaussian assumptions. I haven't seen any papers where people
Hello. Hello, Nibet.
Sir, the voice is not audible, sir.
Yeah, this from the speaker.
Yes, sir. Yes, sir.
So he seems to have lost contact.
Yeah, we lost him.
So Ambika, how are you?
Yeah, good. How are you, sir?
Yeah, it's going on.
He's back.
Yeah, he's back. Yeah, we lost you, Professor Lehnertz. Professor Lehnertz, are you hearing us?
He's muted.
I think you are muted. How to tell you?
Maybe in the chat. Yeah, he's sharing again.
Yeah. Yeah, please.
Professor Lehnertz, you
Professor
are
Lehnertz.
muted. Unmute, please. Yeah.
Please unmute.
Can you hear me now?
Yes.
Yeah. Okay, good. Okay, then now we can go back and continue. So what I was just explaining here with the impact of on interaction measurements. Yeah. So any kind of relationship between different brain regions is also strongly affected by the circadian rhythm. But you also see something that is not easily explainable by simple superpositions. Yeah. That looks more like you have some non-autonomous system that is then also being driven by something that has some kind of periodicities, but not fully. So I haven't seen a good model yet that explains these sidebands that we see here. And depending on what you study, it is not just triplets, but you can also have quartets or quintets that pop up around the 24-hour peak. Also interesting, if you take the intracranial data, if you look at this distribution that you have here over the full day, the same data, you study the phase, or you take the same data and you study the Pearson correlation coefficient, you see that some diurnal cycles are delayed in some sense. So, for example, the phase coherence is 3 to 6 hours ahead of the data that you get from the Pearson correlation coefficient. If you see something like this and you ask, why are there contradicting findings concerning, I have this and this indication from the data that I have in the morning, and I have this in the afternoon, and then the other people come up with, but I have measured the functional connectivity in that way, you should not wonder that you see these differences. Yeah? Because the impact of biological rhythms is still poorly understood. And if you go then for changes in network properties, this is just some example. What I show you is the clustering coefficient, the centrality of different nodes and edges estimated with either the phase coherence or with the Pearson correlation coefficient in the different data sets that we have here. You see, not even this is stable. You see very strong fluctuations in this the characteristics of circadian rhythms. Also interesting here, if you take the same data set, you concentrate on the recording side more in the frontal and more in the back. Sometimes you have a stronger impact than other brain regions. What is this? If you have some impact that comes from the sun, why should it affect differently your brain regions? So many questions that pop up just from the from what you see from these different simple sets of data that we have here. But what it makes is the suitability and reliability of any analysis techniques that is on Gaussian distributed data. This is for most every analysis technique that needs to be questioned. Yeah? And then, of course, the reproducibility and interpretability of findings. This is strongly impacted by these aspects, something that is mostly not taken into account. Yeah? And if you then go for infradian rhythms, so anything that is age dependent, of course, we know something about aging, but how does this really affect brain? These are ongoing studies. We have some study that is currently being done here from the Center of Neurodegenerative Diseases. They follow patients over 50 years to see what are effectively changes in the brain. This is just due to aging, so mostly unknown what we effectively have. So we would like briefly to come to an end, and we would like to briefly touch upon modeling of epileptic processes. There's, of course, lots of methods available to study what is going on and what could be some kind of a mathematical model for seizures or for epilepsy. And if you go to the literature, you will be overwhelmed by what has already been done, and then you need to ask, what do I actually want? The first thing that you need to set up, on what scale do you want to model something? Yeah, you can go down to the level of single neurons, from very simple models like integrate fire, or you can do even pulse coupling, up to realistic Hodgkin-Huxley models, and you can induce whatever you want. Yeah, so it is mostly there. You can go for small networks, single cell models, distributed neural networks, from up to network size of 10 to 5. You can take the realistic connectivity into account if you have the data. But you can even go now and estimate models where you also include not just the neurons, but also glia cells and so on and so on. And then comes the transition. If you go to the large scale, you typically go either for some kind of neural population model, or you have anything that is somehow related to ODEs or PDEs or whatever kind of differential equations you take into account, and they can somehow replicate some phenomena. Yeah? And what you also find is that they can somehow replicate some kind of transitions related to either to bistability, or, and that is also what has been shown, some kind of parameter changes, or due to also some kind of noise-induced transitions. If you go for parameter changes, this is something that you typically find in the literature in mathematics or physics journals. Yeah, that makes somehow sense, but if you then trace this parameter back to what is the physiology behind this, then you say this does not make sense, because if you have there changes in the order of 10 to 6 or higher, this is something that you can't even observe in the brain. Yeah? So nice models, but you need to ask, is this really only some kind of a simplification in terms of parsimony, or is this really something that can really guide the other community to say, I learn more about the system? Yeah. This is data from some groups, also some more recent models by Victor Gierza and other people. You have here some simulation of some EEG data that had been recorded, simulation, and this is the data that has been measured. And if you now ask how, if you just look at the differences, you can really say, hey, that looks pretty much like what we can measure. Yeah. the problem here is that if you take these systems here and you ask, for example, in some kind of a neuronal mass model, can I generate seizure activity? Yes, you can do. Yeah. So these models are able to seize. They can show some transition to seizure-like activity. This is not a seizure, but it's seizure-like. And they can also somehow model the spread of this activity. If you then ask, can you stop the seizure? Then you say, no. Once it is running, you are probably switching between two different attractors and one of them is stable. Yeah? And that's it. If you try to get rid of this state and you want to get out of this state, you need to do some kind of a massive intervention in order to get out of this. They are mostly noise driven. And then if you study these systems, what kind of noise do you need in order to do something? Yeah. And you will see that many people are not even capable. They claim something in their papers that they use a white noise driven system, and it's effectively not white noise because they use a simple integration scheme like an Euler, and you know that it's then a Wiener process and many other aspects that need to be taken into account. The bifurcation scenarios that are considered here are mostly simple, as I said, for low-dimensional systems. And what they don't even have is time-dependent control parameters. So anything that you do is based on off of some change, but some time dependence, and how these the control parameters again depend on time, largely unknown. Yeah. Just to show what the impact of the coupling topology is. If you reduce and say, okay, let's go for the simplest model that you can think of. You take pulse-coupled integrate fire neurons. Yeah? This is shown here. This is a network of 250,000 neurons that we have simulated. And we don't do anything with this network. The only thing that we do is we go away from the PDE approach, but we say, we bring this network, we start with a regular topology. We could describe this, but we don't want this. We put this onto a small world and then simulate this large-scale behavior in terms of the firing. So white is firing, black is not firing. This is extremely simple. And what you see is here that this network starts to generate its own rhythm without any kind of control from outside. Yeah? And this generation of this rhythm is such that if you look at the gross activity of this network here, you see this kind of spiky behavior that can, coming back to the discussions that we just had in between, that look like extreme events. And if you look at the distribution, this is mostly Poissonian distributed. So what we know today, this is also some kind of a representation of a channel-like structure in some high-dimensional space that is induced by the topology. And what you observe here is some kind of a rhythm that is not intrinsic to the dynamics that we have here, but is self-generated. And what we observe here are chimera-like states. But the chimeras are not responsible for the generation of seizures, but the chimeras are at the end of the seizure. So the chimera state is something that is also probably a mechanism for seizures to stop. Yeah? And if you then increase the complexity of the neurons, yeah, so you go away from pulse-coupled integrate fire to Fitzhugh-Nagumo oscillators. This is work that we did together with Ulrike Feudel. Again, fixed control parameters, you bring it onto a small world, and what you observe is that this system is capable of generating self-induced switchings between different dynamical regimes. Yeah? And again, this is due to some build-up of some critical mass of channel-like structures and also of mixed mode oscillations that are important for this type of system that you have here. Yeah? It can also generate extreme events in between just from out of the blue. And the same, this is done that work that we did together with Eckhard Scholl from Berlin, where we used, again, Fitzhugh-Nagumo models and then tried to relate this to generalized seizures. In that case, it was an absence seizure from children, where you have this large-scale activities where even in that cases, it is important to take into account the coupling topology and not as much as the local dynamics, the change in the control parameters. You can fix these control parameters, you can fix the dynamics, but what you end up with is then, how is the coupling topology? How important is this one here? And this, as I said, this is not just structure, but it's also the functional coupling that we have here. And this is something that is not fully understood in the brain. So with this, I hope I stopped one of these slides here. So I stop here. I hope I could convince you that epilepsy is some disorder of large-scale neural networks and not just something that is local. It was important to have some shift, some paradigm shift from the localized view to the network view. That was really important for to better have better understanding. What we still need is the data-driven inference of networks and its characteristics. This is something that is there. You can use many of these techniques, but then comes the question of how effective is this? How reliable is this? How can we translate this back to the clinics? Of course, then also the more pragmatic approach. How can we effectively measure these epileptic networks? How can we sample these in space and time if we don't know what this is? Yeah? Placing some sensors somehow in the brain can already induce some kind of a network topology. This is something that you can see in most of the fMRI data, because there you have regular structures, and any kind of deviation from this regularity by construction is a small work. Yeah? So you should not wonder if you see something like this, even without dynamics. What kind of scales are important? This is also something that is not known right now. What kind of modalities is it sufficient to stay with with electrical activity, magnetic activity? How can we combine this with other types of physical observables that we would need? Yeah, and then of course many aspects that need to be taken into account if we go to the long-term dynamics. Yeah. And at the end, this is, of course, then most important aspect, and for me also something that is not well understood. Control in nonlinear dynamical systems is there. We have this many techniques, but if we go for adaptive systems, controlling adaptive systems, this is something which is, as far as I know, even in mathematics, not fully understood. Yeah, that brings me then to this famous book here by Michael Crichton. I think you know this book. Michael Crichton was a neurologist who wrote science fiction. Yeah? And that was one of the first description about in the Terminal Man about an epilepsy patient that were easily controlled by putting some electrodes into the brain and then think you can control this. And this guy killed half of New York or something like this. So that was really a nice story, but it really explains the problems that are mentioned here. So all these adjectives, this adaptivity, the openness, the non-linearity, and also the network. And with this, I would like to thank you for your attention.
Okay, thank you very much, Professor Lehnertz, for a very fascinating talk. I think you have covered the entire scenario of epilepsy, the cause and the possible interpretation and so on. The forum is now open for discussions, comments, questions. Yeah, Ambika already is there. Yeah.
Yeah. So
Ambika, nice to see you.
yeah. Nice to see you also. Very comprehensive, but I have one or two very small questions. We talked about this epileptic brain network.
Yeah.
And its reconfiguration, etc. Was it totally derived from data, or is it from it's purely database?
Yeah.
And when you say you are comparing an epileptic brain network with a normal brain network, is it with the person during seizure-free interval, or is it a totally normal person?
This is compared with subjects that have no history of any kind of neurological diseases, and from the epilepsy patients, we only take data from the seizure-free interval. So you take the apparently normal state of an epilepsy patient and compare this with the hopefully normal state of a normal subject.
Okay.
And even there, if you would concentrate on seizures, this is trivial. Yeah. No. Yeah, because this is obvious. Because now normal subjects will not generate seizures. Yeah. But that was exactly this. Yeah.
And network characteristics that you mentioned towards the end, very interesting study. But these are also data-based. Are you using Pearson correlation coefficient?
Everything is data-based.
Okay.
Yeah.
So it's
I mentioned some modeling studies at the end.
Okay.
We typically do, whenever we develop some methods, we first start with modeling studies to see how sensitive is this to changes, to noise, to blah blah blah, and any kind of impact that needs to be taken into account in order to study
interpret the data-driven approaches, but at the end, then whatever I've showed you here comes from data. Yes.
Okay. Okay. Good. Thank you.
You're welcome.
Yeah. Any other questions, comments?
There was one
Anybody else?
question, I think, in the chat.
Box?
As the brain network evolves in time, will the short-term synchronization arise at the interval when there is the decoupling in the network? Also, what is the average timescale in which brain network alter its topology? Oh, this is a good question. Two good questions. Will the short-term synchronization arises at the interval when there is a decoupling in the network? The funny thing is that you can observe all these phenomena on arbitrary timescales, and this is exactly what I mentioned with the problem of how to bridge the different timescales. If you observe data on short timescales, you will observe something there. You observe something on very long timescales, you will observe similar things. Yeah, like the problem of self-similarity. And distinguishing these aspects, and particularly in terms of synchronization phenomena, if you want to study synchronization phenomena, you need to have at least some minimum amount of data to say now it's synchronous or not. You need to, just for statistical reasons. Yeah, but to say, is this the same as at, you need to have a large amount of any other data in between to say this is specific for the onset of a seizure. Yeah, you can do this with surrogates. There are some surrogate techniques available in order to do exactly these kind of modifications. If you stay on the side of synchronization, so on the term of the strength of some interaction, fine. Whenever you go into causal relationships, if you want to study some kind of directionality, I'm not aware of any network, any kind of surrogate approach that allows you to really judge in a statistical sense directionality or not, so causal relationship or not. And the other question, the average timescale in which brain networks alter its topology. Functional, from the functional side, down to the scale of microseconds, up to the scale of years, and on the structural side, some kind of a delayed interaction between structure and function, anything that is related to chemical changes, hormonal changes, changes due to aging. So choose your time scale, what you want. Yeah, you will find it on any time scale. So there is nothing that is clearly defined. Yeah. As I said, the worst case scenario for any kind of studies, if you want to apply some kind of analysis techniques or even for modeling, if you want to do this in a good sense, you are faced with exactly these problems. I hope I could answer your question.
Okay. Okay, thank you. Any other questions or comments? Yeah. Yeah, I have a very simple question. I mean, normally people are advised, I mean, who are affected by seizure to wear iron bangles to control further. So do you think that it can be explained how it controls?
As I said, the classical ways to control does not work. Yeah.
Yeah. Yeah.
What the current way of thinking is to go away from the massive approach. You take some chemical, you put it onto the brain, and then take care about yourself. This does not work. Local control does not work, probably because people don't target the correct target. If you only concentrate on, here is something that I can see, but I don't see the generator of that, and you then only see the effector, and you concentrate on the effector, but not on the generator, probably not a good approach. Yeah, but that requires a completely novel way of thinking. In terms of how to control networks, any kind of network control techniques so far that I understood is you control nodes, but you never control links, and you never control the whole network, or you control parts of the network in terms of communities, in terms of modular structures, whatever is there. Controlling nodes means you control part of brain structures. but you're not controlling the interactions. And if the interactions is the aspect that is much, much more important than looking at the local activity of some brain region that can also be controlled in a different way, then this will not work. Interestingly, there had been some approaches in the 90s where people, without knowing that, used already something like an edge-based control in terms of surgery. So what they did that was what you do, not surgery by removing parts of the brain, but only disrupting the connections. Okay. And interestingly, the success rate was much, much better. But it was a technique that was done in maybe 3-4 countries in some very specialized units, and people probably forgot this. I hope that there will be some kind of a revival going in that direction. But this then probably also a little bit too targeted. If you want to control a network such that it will not generate an emergent phenomenon, is it a node? Is it the link or the edge? Or what do you need to control? The global control is something that is currently being tested. This is any kind of activation. If you go for any kind of nerves, particularly the vagal nerve or any kind of autonomous activation into the brain, funny thing is it modifies brain networks. How this is modified and if this has now a long-term effect on seizures, this is effective not known so far. It requires much more years. But if you think in terms of controlling an adaptive system, that would require control technique that allow you to de-learn something. In the sense of epilepsy is something that is being generated by itself due to some kind of a perturbation. And in terms of just from this very simple perspective, any seizure is a perturbation to the dynamics of the brain.
Okay.
Yeah. So this is a self-perturbation. And the system brain is these.
I think we lost him again.
Oh. Last part. Nivet, what to do?
So he's back again.
I'm back. I'm sorry, I was again disrupted. I have no idea why.
Yeah.
But the last point was de-learning some, trying to present some kind of a control mechanism that allows you to de-learn something. Yeah. Okay. But now you can ask yourself, will you be able to de-learn teeth brushing? Okay. Or driving a bicycle?
Yeah.
This is probably one of the reasons why we have this old disease. Yeah, it is one, as I said, the oldest disease that is known to mankind, and effectively any kind of control or to understand this is probably an issue of point of view of this disease. Yeah. Okay. And then if you accept this, then you need to, of course, then ask, what is this good for? Yeah. Yeah. But that gets then quite kind of philosophical.
Okay. Okay. Thank you very much, Professor Lehnertz.
You're welcome.
Fascinating talk this afternoon. I think I've learned quite a bit. So thank you very much, and we do hope that we will meet once again.
Okay. Thank you. Bye-bye. Take care.
Bye, Professor Lakshmanan. Bye.
Bye.
Bye. Bye.